Hi everyone, thanks for coming. Welcome to this year's Annual Education Day. So just in terms of some housekeeping, so we're quite keen that you get involved so that we've got a kind of quite a broad, interesting programme that actually highlights a lot of the good things we've done in the network over the last few years, including outcomes of the Systems 2 trial, which many of you will know about. We're going to talk about the imaging that we use at the MDT, which will be relevant, I think, for many of the researching imaging tools and also the clinicians. We're also going to talk about Meso-Origins, which is part of the Accelerator network, and you're going to hear about some outcomes from the network from Matthew Tate in the next talk. And finally, last but not least, you're going to hear from Selina with an exciting trial we've just had funding for, an exercise trial. So there's lots to get through. I thought because most of us are clinical, but there are some who are not, and there are some who are maybe newer to mesothelioma. So in this little 10-minute window, I'm going to just give you a bit of an intro and highlight, just kind of set the scene for some of the later talks. So this is kind of mesothelioma, as you guys all know. It's a tumour that affects the lining of the outside of the lung and the inside of the rib cage. It's driven by asbestos, and the biology and the morphology of the tumour are both quite complex. And unfortunately, we have the highest incidence of the disease anywhere in the world, and the outcomes traditionally have been relatively poor. Many of you will know that the UK remains the kind of epicentre of meso incidents and meso deaths. Australia are fairly close behind us, and the traditional means of exposure has, of course, been heavy industry. So we will all know about the kind of classic stories of the older man who worked in a shipyard or worked in building or asbestos even manufacture. These are pictures of the Southern General, which is where many of us have our clinical practice. It's now, of course, called the Queen Elizabeth, and you can see 3 shipyards within a mile, and of course that's the reason we have so many cases in around Govan. And the picture on the left is Greenock, which is where I grew up. I'm quite posh, so I grew up in Gourock, which is at the very top on the left. So, but my mum now lives down the bottom here. These shipyards have been converted. If you drive through Greenock, the kind of old East India docks are now converted into new housing and things. So, but this is my kind of patch growing up. But you know, Mahendra and I were talking about this just in the coffee, that actually that pattern of exposure is definitely changing, and those of you involved in the medical legal aspects will be aware of this as well, where we're seeing many more women, non-traditional exposures, perhaps through things like schools, council buildings, other environments where we've got asbestos still in place, and we have hundreds of schools with asbestos in it in Scotland. And globally, sometimes mesothelioma is thought about as a disease that why are we bothering, because it will just disappear. But unfortunately, that's not the case. This map shows the countries in the world that actually have an asbestos ban in green, and you can see most countries don't. And in red, you can see the very high users, and the kind of colour panel takes you down through the amount of asbestos utilisation. But you can see enormous asbestos utilisation occurring still in Russia, India, China, Kazakhstan, the Ukraine. The US doesn't have an asbestos ban, and very few other countries. Very few of these countries have any system for managing in situ asbestos. So the big issue is continued occupational exposure, and there's a very active pro-asbestos lobby. As a result of that, we're seeing cases rising globally, and in 2017, for example, there were 35,000 mesothelioma deaths, and that's predicted to continue to rise. So just to kind of move on to what we're here to talk about, really is really just to reflect on the network activities and the things that we do and what we can learn to look after patients more effectively. Many of you are on this slide, so this is how services are organised in Scotland now. We've been very successful in leveraging a relatively small amount of pump priming grant funding, £1.2 million to set the network up, and with lots of help from partners, including Action Asbestos, Meso UK and Macmillan, and the service is now business as usual in National Services Scotland, so it's been adopted by the NHS. And we've worked very hard to support colleagues to get LAT, which is local anaesthetic thoracoscopy, in place so that the diagnostic services are available for all our patients regardless of where you live. And obviously you guys, many of you contribute to the weekly MDT where we try and make best decisions and provide options for patients. And interestingly, at a UK level, we're now actually trying to roll out the Scottish model, as it's been called, to the rest of the UK. So Wales have just had funding for a network similar modelled on our own, and we're trying to set up similarly sized networks in England, so similar numbers of patients where we can have a similar sort of infrastructure to support patients, because actually we're doing it better in Scotland than we are anywhere else in the UK. I would say that, but I think that's true. A large part of what we do is research, and you're going to hear some interesting and I hope exciting outcomes from research studies. Some of that's been translational, and that means really more laboratory based, where we're trying to translate laboratory findings into patients. And I won't go through these in detail, but we're actually presenting several studies at IMIG, which is in Leo this year, next month actually. No, this month, it's June, isn't it? So if you're not going to Leo, you can still register and come to Leo. It's the closest we get to have a Tartan Army session in France, I think, get a few beers and do some science. So, and we've got, I think at the last count, 8 people from the team presenting their research. So it's really quite impressive, the activity that's going on there. We're also, the things that make more immediate impact on patients are clinical trials, so patients we're actually testing different therapies. And we've run, these are all studies that we have run or are running or about to open. You're going to hear from Selina later on about extra meso, which is an exercise intervention to improve patients' tolerance to cancer therapies and hopefully improve quality of life. In terms of radiotherapy, you're going to hear from Barry with the results of Systems 2, which is, again, the UK has led the way in radiotherapy trials in meso, and those have been led by Glasgow. So you'll hear, I think this is only the second time those results have been presented. So that's exciting for us today. And obviously Checkmate 743 was the immunotherapy trial which changed practice. So now Epi-Nivo is standard of care. And so Scotland's patients were involved in that trial, which is a global study, and that's now changed how we do things. I'm not going to go into this in detail, but I think it's probably just important, maybe for those who are only clinical or maybe not, don't have a foot in the research camp, is just to be aware of the environment actually now that we function in. So the meso research programme that I coordinate is now very well funded. So I said that in the past we weren't well funded and meso was really behind other cancers. We've now had over £8 million of funding from CRUK alone. I'll mention Predict Meso, which is the major infrastructure that supports that across the UK. But we've also had 2 programme awards from CRUK, which are focused on early detection of disease and reconstructing how the tumour evolves with the immune system. And some of you may know that the CRUK centres in Scotland were merged fairly recently, the Glasgow and Edinburgh centres. So there's now one centre called the CRUK Scotland Centre. And that centre has 5 thematic cancers of focus. And it's exciting for us that mesothelioma is one of those cancers. For a rare cancer, you know, we've come a long way, and actually that brings us, there's another 4 work packages there, looking at different elements of meso. So Predict Meso I mentioned. I won't go into this in any detail, but I'm highlighting it really because you're going to hear a little bit about Predict Meso from Mark. Predict Meso is an international accelerator network which I coordinate, and we're now in over 50 institutions in 9 countries. and over 80 investigators, and that is a coordinated programme to really accelerate what we understand about how meso develops and how we could develop new drug therapies. Its core business is in 3 countries. As I say, we're in 9 now. We started with 3, we're now in 9. You're going to hear from work package 1 in red here there are 5 work packages, which are all integrated, and I won't go into any detail. But the first work package is where where the meso origin study sits. And Alex is in the audience, who coordinates PRIP-Meso. So if you've got any PRIP-Meso questions, ask Alex. She keeps me right most of the time. But Mark will take you through that. So that's kind of a bit of a flavour of kind of an intro to where we are in meso, and what the environment looks like in terms of research and more kind of globally. I'm going to hand over to Matt. So just by way of introduction, Matthew Tate, given his full name, will soon leave us. Matt's been with us for 3 years. Yeah, it will be 3 years when you leave. Yeah. So Matt is a senior respiratory trainee, nearly a consultant, who's been doing a PhD, partly focused on doing an impact analysis of all of our work. So when we sit in the meso MDT and we make decisions and we try and coordinate care, do we actually make an impact on patients? And so Matt is going to take you through some of those results. So I'm going to hand over to Matt.
Thanks very much. So, yeah, my name's Matt. I'm a clinical research fellow at the moment at the Queen Elizabeth Hospital, and as part of my PhD, I've been looking at impact of the mesothelioma network and how that has the setup of the network has impacted kind of patient care and outcomes across Scotland. So I won't dwell on this slide because obviously Kevin's mentioned quite a few of these aspects, and most of you are part of the network, but that we didn't have national mesothelioma specific services in Scotland prior to 2019, and that the network provides a number of things. So by way of kind of assessing the impact of the network, I've collected data for mesothelioma cases from across the country, and collected into 2 cohorts. So one, a cohort of patients from before the network was set up, and another kind of a post-network cohort, so patients diagnosed from April 2019 up until April 2022. Pulled data from regional data sets, cancer audit databases, and the database that we keep as part of the National MDT, as well as some supplementary data from Public Health Scotland, and use that to compare key outcomes, some of which link to the quality performance indicators which are now collected nationally. And I've been able to look at overall survival, overall patient survival, but also treatment uptake and outcomes related to treatment, how diagnostic pathways have changed, and access to clinical trials, which obviously is very important in this patient group. So this is just looking at some of the quality performance indicator outcomes, and looking at the pre-national network cohort compared with patients that have been diagnosed since the network has been established. And what we're looking at here is so PS is performance status and how well that is recorded. So in what percentage of patients is that recorded at MDT, and then as well how well stage is recorded. Obviously, those are very important for planning appropriate care. How frequently pathology is, we confirm the pathological diagnosis and the subtype of mesothelioma, and then the proportion of patients who go on to get systemic treatment and are recruited to trials. And you can see across the board we've improved on the majority of those metrics. The one exception there is you can see trial recruitment looks to have dropped a little bit in the post-network era, but as I'll come on to, that reflects the pandemic situation over the last few years where trial recruitment dropped off, in all areas. So this is looking at the 2 cohorts that of patients, and the chief takeaway from this is that firstly the baseline characteristics of these patients are similar. So looking at by the characteristics that are down the left-hand side of that table, the patients in the two cohort groups don't differ dramatically. But also we can see that they are generally of an age where treatment we would consider, we're not dealing with very, very elderly patients. We're dealing generally with patients with early stage disease and also with patients with a good performance status. So these are patients who potentially could benefit from systemic treatment and equally maybe patients who would be suitable to recruit to clinical trials were they available. So this is just to illustrate the survival differences, overall survival differences between epithelioid mesothelioma and patients with non-epithelioid subtypes. So this is mainly sarcomatoid, but also biphasic and desmoplastic mesothelioma. And this mirrors kind of the survival differences in lots of cohorts. So people with epithelioid mesothelioma have much better survival. And that's the same in our cohorts. This just is having a look at the differences in overall survival between the pre-network cohort and the post-network cohort of all patients included in those cohorts. And you can see there isn't a significant survival difference there, although there is a little bit of, there is suggestion of some early survival benefit, although these lines cross later on, which means that difference is not significant by this kind of measure. But if we then look at by histology, where we know people with non-epithelioid histology have generally much worse survival. It looks as if that people in the post-network era, so people who have been diagnosed since the network was established with non-epithelioid types of mesothelioma, have tended to, their survival appears to have improved when compared to patients in the previous cohort. Obviously, digging into that is to work out why that might be is part of what I've been doing. So then looking at overall survival in a bit more detail, so trying to correct for some of the baseline factors which I showed you in that table, things like differences in histology and disease stage and performance status. So this is a slightly different way of looking at survival analysis due to some of the specifics of the data, but this is a survival analysis method called restricted mean survival time, and looks basically at survival up to a specific follow-up point and the mean survival up to that point, as opposed to the median survival, which is what I'd showed you before. So looking at this metric, if we compare people in the post-network cohort and the pre-network cohort, there does appear to be a significant survival difference when kind of truncated for 12 months of follow-up. And I've been able to adjust that to account for the baseline variables which I mentioned, and there is still a significant difference in survival, which is small. You can see there is 0.6 months, but that's from 0.6 months up to a year of survival, up to a year of follow-up. So it's not overall survival, it's up to a year survival of follow-up. If we then repeat that for subgroups, particularly looking at non-epithelioid mesothelioma, that difference is even more marked. So there's an even more significant difference in survival there. But there is no difference for epithelioid mesothelioma using this methodology. So next, I had we've been having a look at treatment uptake, and this is relevant in particularly in patients with performance status 0 and 1. And this data has come predominantly from Public Health Scotland, who collect data regarding systemic anti-cancer treatment. And I've been able to see there hasn't been a significant difference in uptake between the two cohorts. So roughly half of patients who are of good performance status have gone on to receive systemic anti-cancer treatment. I have looked at time to treatment, which is obviously less of a relevant metric in mesothelioma, because often we wait and people only move forward to have treatment once they feel that would be of benefit. And then looked a little bit about immunotherapy uptake as well. So obviously immunotherapy was initially available within clinical trials in the kind of earlier portion of the period I've looked at, and then later through the early access to medicine scheme, and then more recently globally to patients after it was approved by the SMC. So actually patients in the cohorts I've looked at, only I think 2 patients who received immunotherapy got it within Checkmate 743, where we've seen a significant survival benefit with immunotherapy. The remainder were probably through the early access to medicine scheme. And as I'll show you later, there's actually, although there was predominantly patients with non-epithelioid tumour getting immunotherapy, there are still a decent proportion of epithelioid cases who received immunotherapy. So then just looking a little bit about where people, kind of what the geographic variance is in people receiving treatment. Obviously that has varied across the country. I think the key thing to kind of here draw your attention to is that of patients who received immunotherapy, that does appear to be, as a proportion of all patients who got treatment, that does appear to be kind of concentrated in Lothian, which I think where the kind of trial centre for the immunotherapy trials were. Obviously, like I said, only a couple of patients actually who were in these cohorts received treatment within the trials, but that may reflect kind of a familiarity with the process of those regimens. So then I've looked into more detail about patients who received treatment, systemic anti-cancer treatment, and looking at survival differences just in patients who received systemic treatments. So this is all patients who had anti-cancer treatments in the earlier cohort and in the post-network cohort, and there doesn't appear to be a difference there in all comers. So this is all patients, not stratified by histology. And then looking at patients who receive, stratifying by what treatment they received, so either conventional chemotherapy or immunotherapy, there doesn't yet appear to be a difference in overall survival depending on what treatment they received. Although you can see those lines are kind of do diverge for the majority of that graph and just cross at the end there. So there may be, and there are quite much smaller numbers of patients here who received immunotherapy. So it may be as time goes on and we collate more data for patients with immunotherapy, that becomes a significant difference, mirroring that was seen in Checkmate 743, where there was a clear survival advantage to getting immunotherapy. So I'm just going to show this slide. So this is so the headline, I think, of this slide is digging into a bit more detail to how survival has changed by kind of time point, by patients in the earlier cohort and the post-network cohort, but also by histology. And the key thing here, I think, is to show that these three, the red line is patients who are in the pre-network cohort with non-epithelioid histology, who we know do less well. The other three lines represent patients with epithelioid histology, who you can imagine those. I've mentioned before that there's no difference in survival in the pre or post-network cohorts, but also that shows patients in the post-network cohort with non-epithelioid histology, and basically you can see now clustering of the survival of those three groups, and the pre-network non-epithelioid patients are very much an outlier. So what we're seeing is that the survival of non-epithelioid patients appears to have improved to that approaching that of epithelioid mesothelioma, which is quite a marked change. And just a little bit in more detail. So on the left, the panel on the left is pre-network survival, patients in the pre-network cohort with kind of stratified by subtype. So there's a big difference between epithelioid and non-epithelioid survival there. And then on the right, in the post-network era, that difference has disappeared. So patients with non-epithelioid mesothelioma in the post-network era are doing much better. And obviously, the most factor in that change is the advent of new and more effective treatments in the form of immunotherapy. And this just shows that of patients who kind of divided by histology, you can see that patients with non-epithelioid mesothelioma have received immunotherapy in a kind of a greater proportion, but it's not universally. It's not that it's only non-epithelioid patients receiving immunotherapy. There is still a sizable proportion of epithelioid cases who are getting that treatment as well. So it may not be the only factor that explains those survival differences. So I'm just going to come on to look at how the diagnostic approaches have changed between the two cohorts. So this is looking at kind of diagnostic approach. and the way we kind of get a tissue diagnosis. And you can see that actually we've been doing more image-guided biopsies in the post-network era compared to the pre-network era. I think the caveat to this slide is that it includes case data up to April 2022 and probably doesn't capture the expanded access to thoracoscopy, which the network has enabled. Several centres have been able to start doing thoracoscopy in the last year or so, and the data probably isn't included in this slide. So if we're to extend this cohort, I'd probably expect to see more thoracoscopy. But also there's probably a pandemic effect as well here, where we pulled away from doing thoracoscopic biopsies and relied more on image-guided biopsies over that era. This is the same kind of data but displayed over time. So you can see the dashed line here in the centre is the setup of the network, and you can see there was an increase in thoracoscopy as a proportion of cases, patients who that was the diagnostic method, and then that dropped off around the time of the beginning of the pandemic and has yet to pick up. But again, this doesn't probably capture the more recent data where we've got rollout to other centres, and so that remains to be seen. So this is just looking at recruitment to studies. So this is all studies, so this is not just kind of systemic anti-cancer trials. This is all studies. And you can see that there's the setup of the network is marked there, but also the first kind of the advent of the pandemic is marked. You can see there's a very marked drop-off, so it kind of confirms what we all know about how clinical trial activity changed around that time. Recruitment dropped to zero essentially for over a year, and then it started to pick back up again towards the tail end of the cohort. Although these patients have been recruited to observational studies rather than interventional trials at present, as those are the studies that are open. So there have definitely been improvements in some of the quality performance indicators associated with the setup of the network. There looks to be a significant early survival benefit associated with being diagnosed in the post-network era, and that appears to retain significance adjusting for baseline factors. The treatment uptake is largely similar, but there does appear to be a real-world survival improvement in non-epithelioid mesothelioma for cases with non-epithelioid disease, and that's probably at least partly explained by rollout of immunotherapy. And then there have been changes in diagnostics and trial access, but we're still probably seeing a kind of a pandemic knock-on effect, and more recent data may show that has changed still. Yeah, so that's all I had to say. Happy to answer any questions if anyone has any.
It's not recorded. You're all being recorded, by the way. Should have told you that at the start. But but with that change in non-epithelioid outcomes, could some of that be the classification of more cases as biphasic? Do we know? Have you been able to look into the data and see in the non-epithelioid group how many of the distribution of sarcomatoid versus biphasic changed? Are we just doing better diagnostics and getting a little bit more of a sarcomatoid element, and maybe that's part of it?
Possibly. I haven't looked into that in detail. I mean, the biphasic is obviously a very small proportion of.
Yeah.
It's predominantly sarcomatoid patients in the non-epithelioid kind of subgroup. But yeah, I guess that's maybe there are patients within a subgroup who are actually behaving kind of on a molecular level more like epithelioid anyway, so you would expect those outcomes to be more similar.
Thanks. I mean, really impressive. It just, it seems to me what's happened is you've got organised, really, and that's, showing in these improvements in survival that it's encouraging. I was just interested, one thing that's not been captured, I don't think, and I may be wrong, is how patients are reporting this. And my hunch, my feeling is patients probably feel they're getting a better service in this post-network era. So I think you're not doing that just now, but if you're not, how would you plan to do it? Because clearly you should.
Yeah, so we haven't formally done that to date. Obviously there have been kind of patient experience. There's been patient experience work done before, I think before the setup of the network, and we have looked at that as to how we could kind of repeat a version of that, or generate comparable data to look at how that has changed over time. But that's kind of in an early stage. But definitely, I think that's very important, because I think that would be an almost kind of greater impact, that the patient's experiences.
Quality, they're moving. Survival is important, but quality of life, patient-reported outcomes are becoming arguably as important. So it'd be quite easy to do that, and I think most patients would be keen to collect that data.
So, there was this thing, the MORE study, which is a Meso UK study you probably heard of, which was patient experience, and that was pre-network. And there's no plan to do that again, but we are trying to. There's a patient-reported outcome tool that's embedded in an app that's been produced by Meso UK. And Anna, who's the network manager, who's down the front, being very quiet, trying not to say anything, has been in discussions about the logistics of actually using that across Scotland's health boards. There are some information governance hurdles to get over because of where the data's stored and who owns it and all that sort of stuff. But I think you're right. I think it's really important that we are able to capture that patient experience and quality of life stuff, because I think some of this improved survival it can't be all related to immunotherapy, because only a minority got immunotherapy. So there's some more general, just being looked after better, or something that is just not measurable in the data set at the moment. Yeah. Okay, well, I think we're kind of roughly on time, so we'll move on, I think, and we'll move on to the next talk.